So yesterday we saw the things related to angina and acute coronary syndrome. We have seen various situations. We have seen what are the consequences of it, and we have seen A, B, C, D, E of the treatment, wherein A means anticoagulant, B are beta blocker, C are calcium channel blocker, and lastly we have seen E, that is what is the benefit of exercise and all. Now let us go for the treatment part. What are various treatment options are there, and as we have seen, the most important treatment is renin-angiotensin aldosterone system blockers. They are used. So what evidences actually it is showing? What are the evidences which are available and what it is showing? So these are showing the first class, that is they are important. They shows very good safety, as we have seen, isn't it, where the benefit is much more than the risk. So they are used in all patients with left ventricular ejection fraction which is less than what is LVEF, that is left ventricular ejection fraction. What do you mean by ejection fraction? That is, it is the fraction which is there as compared to the normal ejection. What is ejection? That is cardiac output. So cardiac output when reduces, then it becomes fraction of that 100%. So we call it as a left ventricular ejection fraction. So when it goes less than 40%, then it is mandatory, or it is compulsorily prescribed that this renin AC inhibitor or ARBs are prescribed. Particularly also those with diabetes or chronic kidney diseases, in that also they can be used. Only situation where they cannot be used, that is if they are contraindicated. If example in asthma or cough like situation, then we can go for ARBs. They can also be considered for all other patients. It has been found to be lower risk patient with normal left ventricular ejection fraction. There is no big problem, and where cardiovascular risk factors are well controlled and where the revascularization has been performed, their use may be considered option. Okay, they may not be that compulsory, but in other cases they are compulsory. So if we see that what will happen because of this drug, we will see that it will have the maximum flow and resting flow that can be improved, particularly coronary flow reserve, that will be improved with these agents. Then what are various situations? Let us see. Whenever there is a problem, when the person feels the signs, chest pain and then pain in arm and feeling that heaviness in the chest, then we can go for diagnosis, that is of acute coronary syndrome. And there can be two types, as we have seen. It can be ST elevation or no ST elevation. If there is a ST elevation, then we can say that it is a chance that it has got a myocardial infarction. Myocardial infarction can have both situations. One is with STM, that is ST elevation, which is major portion actually with that, and non-STEMI is a smaller portion which is having. Both can have myocardial infarctions. Then indeed again there can be two versions, that is no changes in Q wave in myocardial and Q wave changes in myocardial infarction. So these are two things which will be diagnosed. This can be checked. While when there is a no ST elevation but severe chest pain is there, then it can be unstable angina. Okay, so there are three conditions, or there are group of condition we are getting, that there is a chest pain, the patient is severely suffering. Then immediate thing which can be done is, because even it will take long time to get a result of the various biomarkers like creatinine kinase, that is CKMB, LDH, that is lactose dehydrogenase troponin, and so many. So what is immediate can be done is immediately place the electrode, go for ECG. ECG can be done within minutes, and this ECG once got, then you get few things, that is either there is a ST elevation or ST not elevated. If ST is elevated, then there are maximum chances are there that is myocardial infarction, or it is almost confirmed that it is myocardial infarction, but there are chances that there is no involvement of ST elevation. So it can be NSTMI, that is non-ST elevation of myocardial infarction. Now this myocardial infarction, in that we have got Q wave changes, and on that basis we can have. And second way is, if there is no ST elevation, then maximum chances that it can be unstable angina. So this is the reason, if you you can see this figure, this is the reason why now I am taking both simultaneously. We have done angina separately, we have done MI separately, but now to show the differences between these two, angina, this is a severe case, unstable angina, this is a severe most case of angina. But here one thing is very important, that the patient was diagnosed since many days, most of the time. Rarely it will happen that patient was suddenly diagnosed. Otherwise, in most of the patients were diagnosed when it was stable angina, and if it is not treated well or the lifestyle management has not done, then it might have got converted into unstable angina. However, in myocardial infarction, the most probable, in most of the cases, there is no previous sign. All of a sudden, the plaque which was there, that plaque get ruptured, and because of that it causes the occlusion of coronary artery wherever possible, and then the next area becomes ischemic. So these are two very important things which are there related to coronary artery syndrome or acute coronary syndrome. Then next in that is, when we will go hospitalization, if you consider US, then there are around 1.8 million hospital admissions. Same is the case in India also, quite a very high number of are there, and in that maximum are there this unstable angina or non-STEMI type of there, while ST elevation myocardial infarction are around just 0.41. So only just we can say 1/3 of it they are present. Then next in that is the spectrum of the acute coronary syndrome. So what are the situations are there, how we can go for clear diagnosis, what are the situations which are there. So first is clinical findings. What are the clinical findings? What clinical findings are telling? That is non-cardiac chest pain, which is atypical pain. Then that means that can be one of the sign. Then if it is a stable angina, then exertional pain whenever person is climbing hill-like structure or going upstairs or walking too much or going for physical exercise, then there is a pain is there, so we call it as exertional pain in chest. Then during rest, if it is pain, or post myocardial infarction, if there is a pain and already there is a diabetes mellitus and prior aspirin was going on, then we can think that it is because of unstable angina, or it is this is non-STEM, that is non-STEMI, that is non-ST elevation myocardial infarction. And in case of STEMI, that is in case of ST elevation myocardial infarction, because it is acute one, the pain will be continuously going on, pain will be there. Then if we will see the cardiogram, up to stable angina, it may not show much changes in that. Then if it is a unstable angina and no ST elevation myocardial infarction, then we can check, we can find the changes in the ST wave, and T wave changes will be there. That is, it can be, as we have seen, it can be ST inversion because it is non-STEMI, that means there is no ST elevation, and Q wave changes are there. While if it is STMI, that is if it is STEMI, then there will be 100% ST elevation is there. It is very clear-cut sign of myocardial infarction. Serum markers will be negative. We have seen various serum marker, if you remember. Serum markers, example of these are LDH, creatinine kinase, troponin, etc. While if it is unstable, slowly we will find that they are turning into the color changes you can see. So when it becomes unstable angina, because these are all related to ischemia, as ischemia increases, because of increase in the ischemia, there is a damage to the cells, or we call it as ischemic injury. There can be necrosis or apoptosis. This kind of cell injury will be there, cells will be destroyed, and then cellular content will come into blood, and because of that we can have two basic reasons. Where there is a no big injury, it will be negative. Once there is a cellular injury, all the content in the cell, it will come into blood, and because of that the levels of these markers like creatine kinase, troponin, lactose dehydrogenase will increase, and that are the signs. They are very easy signs for that. Then risk and assessment, there is a low risk or low probability. Then in stable angina there is a again low risk. In unstable angina and on STEMI, medium risk, and with ST elevation myocardium there is a very high risk. So the comparatively the patient will have highest risk in the myocardial infarction, and then gradually it will be less in non-STEMI, and thereafter unstable angina, then stable angina, and then what are the diagnostic and treatment activities. So check out what are the situations, diagnose whether it is myocardial infarction or acute coronary syndrome, what are the reasons, check it out. If it is, once it is you have confirmed it, then accordingly go for treatment. It can be as normally we have seen all this treatment. Aspirin is given, low molecular weight heparin or heparin is given, then clopidogrel anti-ischemic treatment is there, that we call it as a early conservative treatment. But in STEMI you must have to have thrombolysis, either by using thrombolytic drugs like streptokinase, urokinase, alteplase, there are many such agents, or go for PCI, that is percutaneous intervention, or we call it as a PTCA, that is percutaneous thrombolytic angioplasty. So these are the ways by which we can do it. Aspirin plus GP2 inhibitor, that is like clopidogrel plus heparin, low molecular weight heparin, anti-ischemic drugs, they must be given during these medium risk conditions. So this is how there are change in the treatment will be accordingly changed. Then next in that is what are the managements of the STEMI. So these will be ST elevation, you can see the ECGs, particularly type 2, and this is normal like situation, and here you can see that the ST is elevation, this is a ST. In whatsoever graph you can see, there are many graph you can see, and this will show the ST elevation. So this ECG will be clear, that will be immediate sign known even before something comes, people can or clinician can diagnose it. So chest pain pattern, they are suggesting an acute coronary syndrome. Once it is there, then go for rapid care. Aspirin is 160 to 350 325 milligram chewed. Then nitroglycerin 0.4 mg every 5 minutes for 3 doses. Morphine sulfate to reduce the pain intravenously. Then establish intravenous access, obtain blood for initial laboratory work for biomarkers. Immediately continuous ECG monitoring you put on. Initiate the supplementary oxygen therapy. Then obtain focus history and examination. So these are immediate goals. So it is very fast. These things are to be done very fast. Once it is done, then go for 12 lead ECG. Then repeat it if you cannot diagnose every 5 to 10 minutes interval. And if it is strong susceptibility to ischemia and no ST elevation, then check other things. If normal or non-diagnostic ECG, if it is there, then continue evaluation. Then in the emergency department, monitor the bed, then repeat the ECG and cardiac enzyme at every 6 to 12 hours. And if by chance there are evidence of ischemia infarction are there, if there are no such thing, then go for stress test. What is stress test? I told you earlier that we call it as a treadmill test or like that. Treadmill is a exercise machine you might have seen, or walker we call it, as a that in room you can keep and the person walk in it, the belt moves. So along with ECG is performed. So once the person, when the person walk, then go for that, the stress test is there, and if it is yes, then treat for non-ST elevation acute coronary syndrome. Check it for that. We have already seen the guidelines for that. If there is a ST elevation, or there is a no such new activities like that, then go for beta blocker, intravenous nitroglycerin. If there is a persistent chest pain, then go for morphine, give clopidogrel, and if possible go for PCI, that is percutaneous intervention, and these are various drugs. Then if PCI, if it is there, then go for it with goal less than 90 minutes, or thrombolysis within goal of 30 minutes. Do it so that immediately reperfusion to the ischemic tissue will be there, and this will help in patients. Now, as I was telling repeatedly about angiography, so this is how the angiography picture looks as. This angiography will show that, see, here is a blockage, up to this there is a good blood supply, but thereafter it is not there, the dye is not going. Okay, so since the dye is going, it is appearing over here, but dye is not going to this part, so that is clearly indicating, that means it is the blockage. So if the blockage, as it comes nearer, so you can imagine every position, if it goes proximal, means even before that, then still more blood vessels it can occlude, or many branches will be occluded. So anywhere it is causing occlusion, that can be seen, that is called as angiography, and this will guide, this helps us to understand how much is the blockage, how much the distal area or subsequent areas are damaged. Now how it is done, that is known as a balloon angioplasty. So whenever that is located plane, on the basis of angiography, plaque is located, the catheter is there, catheter is inserted, the balloon is inflated, and then the plaque will be pressed with the balloon, so that it decreases, and then that will be done. It is simple, is called as a balloon angioplasty. Then another thing is, when most of the time that is not sufficient one, because in most of time, because of the plaque atherosclerosis, that is rupture of that, some of the area has already got damaged, and therefore there is artery does not have that strength. So for that, there are many chances that there can be reappearing of the growth over there, or development of atherosclerosis. So various stents are there. So what is done is, again it is along with balloon, it is there, it has put, and then with balloon it will be inflated, and then once it is expanded with the inflated balloon, the stent will remain as a spring from inside the arteries, and it will give support to artery, and it will not allow artery to collapse, which is because of the collapsing, the arteries are stopping blood flow, so it will not happen. Now what are the various management of unstable angina and non-STEMI? So go for anti-ischemic therapy, go for oxygen therapy, give bed rest, give ECG monitoring, add nitroglycerin, give beta blockers, AC inhibitors, go for antithrombotic therapy, antiplatelet therapy, anticoagulant therapy, etc. And these are the therapies which are important, and simultaneously it has to be done. So we know there are various coagulation mechanisms, so, and there are many drugs which can affect it. So example of these are, once it is there, if you remember hemostasis in blood, particularly what happens into that is, there are intrinsic and extrinsic pathways which were responsible for formation of fibrin threads, and before these fibrin threads there is activation of platelet, and these platelets are activated. Because of the activation of platelets, these platelets become sticky, they stick to each other. This is because of various receptors which are present on that, and collagen, leukocytes, etc., they will do it. So we have got various drugs which are acting at various levels. Example is low molecular weight heparin is acting on leukocyte, platelets, and even in the last one, that is formation of fibrin. Then another one is activation of platelets can be inhibited with aspirin and thienopyridines. Then once the platelet are activated, then they cause the cross binding or cross linking with the fibrinogen, and because of that, in the network of this fibrinogen, these platelets are just like stone and wire are there. So stones are there, and when the dams are made, so stones or wires are there, and that stones are put. So platelet here are acting as stones, and they will get linked with the fibrin. So fibrinogen cross linking is there. This is because of the receptors which are called as a GP2B and 3A receptors. So we have got drugs which are acting as a antagonist of GP2 and GP3A receptors. Example of this is a clopidogrel, and then it results into platelet aggregation, which along with the thrombus formation is responsible for that. Lastly, once the another is from tissue factors, these various factors are activated, like factor 10. This is prevented, this is inhibited by low molecular weight heparin. Factor 10 causes activation of prothrombin to thrombin. This thrombin plus fibrinogen will cause fibrin. Fibrin will result into formation of thrombus, and this thrombus to what we call as a clot along with platelets, and this thrombus is responsible for the occlusion or obstruction. Thrombus is actually clot of blood inside the blood vessel, and clot we call it when it is outside the blood vessel, where on the site of injury, when it is there we call it as a clot, but when it is inside the blood vessel, then we call it as a thrombus. Then next thing in this is there is a plasmin is there, which is activated from plasminogen, and thrombolytic drugs are causing activation of this plasminogen, and therefore it result into fibrin degradation. So this is all about various drugs which are prescribed in this angina and myocardial infarction. So when we say what are the effects of this, these are when aspirin is given in the treatment of acute coronary syndrome. So if we see the probability of death, that has been reduced from around 0.15 or around 0.20, which was maximum, to 0.05 to 0.7 around. So it has been reducing, or it has reduced the risk several times. This is how the aspirin is benefit. Aspirin, already we have seen this, that aspirin at high dose is not that effective, and aspirin only at the dose of 75 to or rather to 320 is the most effective dose, and that is the most better one. We have seen at various trials. We can compare with the heparin plus aspirin with only aspirin alone, and it shows that if heparin and aspirin are combined, then various tests show that it gives still better impact, and it shows lesser mortality comparatively, and the impact is better. Then there was a trial that was known as a TIMI, that is thrombolysis in myocardial infarction. That was a trial. Then there was another trial like ESSENCE, that is efficacy and safety of subcutaneous enozapam in non-Q wave coronary artery events. These are various trials were there. So these trials, they have shown that the enoxaparin is comparatively better versus unfractionated heparin. Enoxaparin is having more favorable effects. So low molecular weight heparin, it has got its own limitation, because it is indirect inhibition. It is depending on the antithrombin which is present in the body. It has got inability to inhibit the clot bound thrombin. It may not able to do it. Catheterization lab is required, slowest onset. It has got longer half life, and with enoxaparin there are no standard set test to measure the level its effects. Also during CAGB there are concerns regarding the long life of low molecular weight heparin, and monitoring for the factor 10 which is possible, but then what is to be done, it is not clear, and it can be expensive, and therefore there are some limitation, but it is not there with all low molecular weight heparins. Some are the better one. Now what we are doing is we are checking clopidogrel plus aspirin combination uh, and placebo and aspirin, or aspirin alone without combination. So we can see that when both are combined together, that is clopidogrel plus aspirin, it is reducing, or it is decreasing the hazard rate by several times, that is 20% reduction in rate is found. So this is how we are getting idea, that is which are the best treatment which are there, and accordingly what we can do. So here we don't have a single treatment, just like in pharmacology when we say drug acting in angina, we do not classify any kind of, or we do not add any kind of drug which are acting on platelet, because we study it in different chapter, that is platelet inhibitors, or which study heparin in other chapter. Here we are we have to make it simultaneously, what's your treatment we are giving. This is how we are working with, this is how there is a difference in therapeutics. So what we are going for, the treatment with this clopidogrel or GP2B3A inhibitors, and it shows that they are effective, they are very good, and they reduce the mortality even before percutaneous intervention and after post-cutaneous intervention. So these are very important part of treatment. In hospital, mortality is lower with early use of this clopidogrel. In hospital means the patient which are admitted to hospital, and immediately if these drugs are given, then their mortality can be reduced. Then the risk score for unstable angina or non-STEMI. So if the age is above 65 years, if there are more than 3 coronary artery disease risk factors are there, you know these risk factors, example are what? Increase in lipid profile, increase in, or there is a diabetes, cigarette smoking, alcohol smoking, these are various risk factors, sedentary lifestyle, obesity. So any of these, any 3 are there, then the risk is more. Prior stenosis is there, prior coronary artery disease is there, then aspirin is used in last 7 days. More than 2 anginal events were occurring less than 24 hours. There is a ST deviation, up and down is going on. Elevated cardiac markers are there like CKMB or troponin. Then it gives that these are people are having at very high risk, and they need to be treated vigorously. So this course, on that basis you can predict, and accordingly what will be happening, that is 30-day mortality, how many people will die within 30 days. This can be predicted depending on that. So these are the scores which are given for various risk factors, like if age is increasing, then it is given 2 to 3 points. If the systolic blood pressure is less than 100, then it has not given few points. Heart rate is less than more than 100 beats per minute, 2 points. So like that, when you calculate all the point, as the point increases, then the death will occur earlier, like that. So these are same type of data, same information are there, where rate of composite and endpoint in 14 days is there with number of risk factors. So this will give again idea about various situations. This is one more trial was there with a famous study that was known as Gusto, and correlation of 6-month mortality with the baseline ECG findings. So wherever there is a ST depression with acute coronary syndrome, the mortality was more. Then it was followed by ST elevation myocardial infarction with fibrinolytics, and wherever there was a T wave inversion, in that cases comparatively mortality was lesser if we go for 100 to 80 days observation. So mortality rates according to the level of cardiac troponin, if somebody checks, then it can find out, or one can find it out, that this troponin level predicts the risk of mortality in ACS with in last 42 days, and where it increases when if it is 0 to 0.4, then mortality is less, it is 1%, and as you go ahead, then mortality will go on increasing. So this is how again mortality will be based, or which can be related with the cardiac troponin content. It is simple. More troponin release, that means more cells are damaged, and more cells are damaged means more chances of death, because if it is these are affecting function of cardiac function very severely. Then various other trials like TM18 studies, it shows that death and myocardial infarction or rehospitalization for these patients. So if the strategy, invasive strategy, what is invasive? CABG and percutaneous intervention, that is PCI, or we call it as a PTCA or angioplasty. If it is there, then the mortality is comparatively less, while if it is conservative treatment like thrombolytics or something like that without going for, then slightly mortality can be more. So various drugs which can be given for chest pain and classification of trials. So we have got class 1, 2, 3, 4, 5 and class X. So class 1 is called as a STEMI, where chest pain is there with ST elevation or new findings in the these various blood levels of biomarkers. Acute revascularization followed by the cardiac ICU admission. Cardiac ICU means what we call intensive care unit admissions. Then class 2 are the unstable angina having NSTEMI, that is high risk patient. These are positive, there is a positive initial cardiac markers, there can be ST depression, and the score, TMIRI score is greater than 5. They have continued angina requiring for intravenous nitroglycerin drip. Then they may have congestive cardiac failure. Their blood pressure, systemic blood pressure can go less than 90, or it can be greater than 180, like that. There are mitral regurgitation, and recent this ACS is there in this patient in last 30 days. So in that patient has to be admitted to this cardiac ICU. Class 3 are the unstable angina, no initial increase in cardiac marker, no, the ECG is normal, ST depression is there, no CHF, no recent ACS, TMIRI score is 3 to 4, and the patient has to be admitted to telemetry. Telemetry means in USA this kind of facilities are there where they can telephonically diagnose and treat the patient emergency without shifting to hospital. So simultaneously it can be there. Then next is unstable angina with normal ECG, no initial increase in cardiac markers, no history of coronary artery disease, TMIRI score is less than 3, no ongoing or recurring pain. So admit to chest pain service or chest pain center in emergency. This one, class 5, no cardiac chest pain, workup in this emergency room with appropriate referral. Class X, these are the critical cause of acute chest pain other than ACS or ACS combined with other acute critical life-threatening disease. This patient has to be admitted to intensive care area like MICU or CICU, SICU or cardiac ICU, whatsoever it may be, medicine ICU or surgical ICU or this cardiac ICU, whatsoever possible. In that condition it has to be immediately put into it. And lastly we will have the algorithm for chest pain, what are the various medications which are there and what we shall be doing. So this will clear our ideas. Example, what are the diagnoses whenever there is a chest pain is there or some symptoms are there which are suggesting that there is a acute coronary syndrome, then what we shall be doing. So there can be various possibilities. So there is a diagnosis that shows there is a non-cardiac situation is there. So in that case, treatment for that particular problem which was diagnosed, and go for treatment. It shows chronic stable angina, then go for the guidelines of ACC, HA or ACP and check out the guidelines for chronic stable angina. If it is a possible ACS, then check for non-diagnostic ECG, normal initial serum cardiac markers, what are they are. When it is clear that it can be definitely ACS, these are not clear about it, but when you will go that it is definitely ACS, then what, there are two options, either it can be ST elevation and because of that it is a myocardial infarction. In that case, go for the reperfusion therapy, check it out and see the ACC AHA guidelines for the acute myocardial infarction. Then next is if in this ACS it is not clear about or ST is not elevation, then ST and or T if is diagnosed and there is ongoing pain, then go for positive cardiac markers, check them out. If they are positive, then admit the patient to hospital, go for the treatment. If the non-diagnostic ECG is normal, the initially serum cardiac markers are okay, then observe the patient for some more time, follow up for 4 to 6 hours, check ECG again, check cardiac or take cardiac markers again. And there are two things again possible. There is a no recurrent pain and negative follow-up studies. Then check the stress study or TMT study as we call, and then go for final judgment. And if it is there, then go for that the treatment of ACS or accordingly go for the treatment of this ACS, that is acute coronary syndromes. So this is how guidelines are there. This is how it is explained that how coronary diseases are treated and how we have to distinguish between AC, that is angina and myocardial infarction. So these are very important. There is a difference in the diagnostic feature in the MI and angina pectoris, or unstable angina rather. Then again we have seen the differences between various drugs, in what condition they are used. As we have seen, most of the conditions are same, variation is small. Most of the conditions allow maximum amount of drug or maximum variety of drug. So this is how we have studied the drugs acting on myocardial infarction or drugs acting on angina pectoris. So if you have any difficulty, you can put it there, and take care, be safe.